I just heard from Sheila, and she unfortunately won't be able to join us. So that was false advertising. We will not get our Bartlett updates today. But that gives us time to have a really relaxed discussion about Cabenuva. And just in terms of what's upcoming, so we have that today, and then next week is Thanksgiving holiday. Then following that, we have a talk on cardiometabolic disease with Dr. Sarkar from the Division of Endocrinology, which should be really fantastic. So please, everyone, make sure to join for that. And then on the 9th of December, we'll be back to cases. And I already have a few, just because this question came up. So please just feel free to email me. You can email a JH number. Just make sure you put secure in the subject line. And then you can outline the case, your questions, or we can have a quick call if that's useful. And usually what I'll do is go through the chart and try to pull together the slides to streamline the discussion, and then ask you for the fill in on terms of clinical details. And we do this for two reasons. Number one, so that there's no like negative work association with actually doing cases, bringing cases forward. And number two, because then we don't have to get CME approval for everybody. As long as I'm making the slides, we only have to get CME approval for me. So very practical reason in the end. So with that, I will turn it over to Christin Kilcrease, who I believe needs no introduction, but is our absolutely fabulous pharmacist who can assist with general medical problems like hypertension management, diabetes recommendations, but also has a really wide range of expertise in HIV that she came here with her experience before. And I may be wrong about this, but were you in Oklahoma before, Christin?
Yes.
Yes, and so we've been very fortunate to have her here working in the pharmacy along with Matthew Langell and others to really just allow us to deliver the best care to our patients. So Christine's going to update, Christin, not Christine, is going to update us on Cabenuva.
Thank you for the introduction, Eileen. Let me just try to share my screen. Let's see. Can you guys see that? Can everybody see my
Not
slides?
yet, no.
Ah. Let's see.
So I think we see your desktop. There we go. Perfect.
Okay.
I love your desktop, by the way.
Thank you. Okay, so thanks everybody for joining. Wanted to give everybody an update about Cabenuva, what we have going on in the pharmacy, a little information about the implementation team, and the collaborative work that we've done with the nurses, physicians, and the pharmacy and pharmacy technicians today. So I have no relevant financial disclosures, relationships, or commercial interests to disclose for this presentation. So the first part of the presentation, we'll go through the overview and the process of the injectable injectable ART in the pharmacy and in the clinic. However, the second portion of the presentation will review the confirmed virologic failures that we're seeing in the clinical trials with long-acting cabotegravir rilpivirine. And so I would like to leave a little bit of time at the end for some discussion to occur to get some input and feedback from the different clinicians on the meeting today. So just briefly, long-acting cabotegravir rilpivirine is indicated for the treatment of HIV in patients that are at least 12 years, age 12 years old or older. These patients must be virologically suppressed with no prior treatment failure. It is an IM injection with the preferred site for injection as a ventral gluteal. As far as ideal patients, we are looking for patients that are virologically suppressed and adherent to their current ART and have been suppressed for at least 6 months. And they're willing to come to frequent provider appointments, and they're interested in decreasing their pill burden. So about the dosing, the initial indication for dosing was the monthly indication, and you can see that kind of to the left of the table. The FDA came back, updated the labeling to every 2-month injections, And so it comes in 2 different dosing kits. Both monthly and the every 2-month dosing start with the 600 milligrams of cabotegravir and the 900 milligrams of rilpivirine. At month 2, the dose is lowered for the monthly frequency. For the every 2-month dosing, the first 2 months are actually consecutive monthly doses, and then starting at the 3rd month, you will see that that's where the every 2-month dosing starts. The FDA updated the labeling in March of this year to say that the oral lead-in is now optional, and that's data that came from the FLAIR trial that we'll talk about a little bit later. So looking at the operations that we have currently, we're currently set up to give injections in both Bartlett and Green Spring. With plans to expand to Harriet Lane and Bayview. We're still working on a couple of things with those 2 additional locations, but want to be able to offer that to patients that are seen at those locations so that they don't all have to kind of trek over to Bartlett for whatever reasons, whether it's parking issues or privacy issues that they're concerned about. Wanted to be able to expand that service to offer it to patients where they are currently seen. For the most part. Right now, we are operating on a referral date-based waitlist system to help us organize the patients that are interested in receiving the long-acting injectable. And so many of you have already been sending your patients who are interested. We've been putting those patients' names on a waitlist with the date that they were sent over to the team. Our appointments and our availability have been limited by our resources. Currently, we only have 1 Bartlett nurse that's administering to patients in the clinic, and that's Stephanie Thornton. She administers to patients every Tuesday and Friday mornings of the month. And then we were able to work with the home care group and lease a nurse to come to administer the injections to patients who their insurance provides them coverage through their pharmacy benefit. That nurse comes every 2nd and 4th Tuesday morning of each month. Good news, Matthew Langle and help with a couple of physicians, Joyce Jones and Yuka Manabe, were able to get some legislation passed. And so now pharmacists are able to administer this to patients. And so we're training pharmacists currently so that we can expand our availability for patients to receive the medication. So where are we now as far as our patient numbers? We have about 60 patients total who are receiving long-acting cabotegravir rilpivirine. As you can see the breakdown there, we've got 26 that are receiving it through their pharmacy benefit, and 8 of those are at Green Spring. We have 34 that are receiving it through their medical benefit, and that's through the clinic. I'll expand upon pharmacy benefit, medical benefit a little later in the presentation. We have about 95 on our wait list. Again, we are working to get that down. That was our rationale for trying to get our pharmacists trained so that we could increase our availability to be able to offer this to our patients in the clinic as well as the pharmacy. And so we're working to get that number down, but in the meantime, we're training. We have approximately 80% of our patients that are on the every 2-month administration, and we've had a low number of patients who have discontinued. Mainly 2 patients have transferred care, 1 discontinued just to chronic no-show, and then adverse drug reaction. And so that 1 patient appeared to have an adverse drug reaction. He received the oral lead-in and then the first loading dose and then declined the maintenance dose. The adverse drug reaction that patient experienced included muscle and joint pain, weakness, and dizziness. And he just went back to, we just transitioned him back to his previous regimen with no issue.
Christin, can I just ask, how long were the side effects experienced by the patient?
From what I could tell, I couldn't tell in the documentation when I went back to look. because he was kind of early on. It just noted that he had experienced those things. And so I thought it was interesting that he was able to make it through the oral lead-in and the loading dose.
Oh,
And I'm not exactly sure when he experienced, if he started experiencing those side effects during the oral lead-in, and he tried to make it through it, and then continued to experience it through the loading dose. That wasn't well documented, so I'm not for certain of when he started experiencing those and for how long.
got it. Thank you.
Mhm. So going into our injectable antiretroviral process overview, this is what the implementation team has come up with and how we are working through being able to provide this service to our patients. And so our first steps are listed here on this slide. You can see that we've got the patient identification and referral, the intake. We've got a whole step dedicated to the benefits review process. The injection appointment, obviously, and then we've got our follow-up to make sure that we are keeping track of our patients that are receiving this medication. Due to its long half-life, this is their antiretroviral therapy, and so we want to make sure that we stay on track, just as we would if they were taking an oral medication. So this step is where the providers or the clinicians are responsible for sending their patients who are interested or they've talked to about the long-acting injectable. The patients are then referred to the implementation team, then places those patients on the wait list again, based on the date that the clinician sent them to those team members. The team members are listed below. With Stephanie Thornton, Sheila Goldscheider, myself, and Matthew Langle.
Hey, Kristen, can I just ask, not to be overly concrete here, but the referral itself, what is the actual referral?
So
is
right
it
now,
a chat message or?
Yes. So right now, yes, it is just a chat message. We're working on a couple of things to make that more standardized. But yes, right now, all we're asking is for clinicians to send over the patient name, the MRN, and then those patients are intake is conducted. So yes, just a chat message.
And then the wait list in terms of thinking about how providers can communicate to their patients if their patients are like wondering where they are on the list. Do you guys have a list that's like an Epic list or something, or is it more just like reach out to the team and say, where is this patient falling in terms of their consideration?
It's a reach out to the team and just kind of see where that patient is as of right now.
Perfect. And then the last question is there like a how there's like a pool that includes all the people in it? Is there like a Cabenuva team, like Epic message list?
Yes, so you're ahead of the game. So we're working on that. We've submitted a JIRA to get that done. And once that is completed, we'll send out an update to the providers to let them know about that pool to be able to send their patients to. And so that just, in case of, one of the team members is on PTO, then that ensures that, patients are still being added or taken care of, or questions can be sent through that, and multiple people will see it.
Perfect. Thank you. And then I see Joyce had just put in the chat that it was her patient who discontinued. Joyce, do you want to add any clinical details? I think a lot of us have some hesitation about things that will be around for a long time. So
yeah, I mean, he's older. This was last year, so he was 81, and he did the oral lead-in, and then he had 2 injections, and then sort of called complaining of these symptoms, and so he stopped, and these symptoms went away. So he's not necessarily a person who has a lot of complaints, just for context.
thank you.
So our next step in our process is just the intake with the clinical pharmacist myself. During this intake, I talk to patients, I review the medication, we talk about the most common side effects that we're seeing in clinical trials. We talk about the frequency. I created an Epic Smart Phrase, Cabenuva, that helps me to facilitate the discussion that I have with the patients, and we'll see that template on the next slide. And then I also do a secondary chart review, and I just go back and I look at drug-drug interactions, any allergies that the patients may have, and then just confirm their hepatitis status prior to switching the patient over. So this is the template of the Epic Smart Phrase. It is quite busy, but helpful for me. I'm constantly updating it as we find out more and more information with the clinical trials. Right now, we're currently utilizing the visit adherence history as a SOLF requirement for eligibility, as we know that it's not specific to the ID provider's visits. And I know I have some patients who will never miss their appointment with their ID provider, but may miss other appointments. So we didn't want to make this a hard stop for patients, but it gives us some sense of adherence that we may be able to expect for a patient who is initiated on medication, given we're short-staffed. We're currently working to make the visit adherence automatically import into the Smart Phrase, but also make it specific to the DEP context that the ID provider logs into, so that it will be specific, so that when it does import, it will be specific to the ID provider, and we'll have a better idea of that patient's visit adherence history. Patients are educated about the optional oral lead-in during this visit. If they opt to take the OLI, then the manufacturer works with one specific pharmacy that has the responsibility for shipping the OLI to the patient. So during this visit, if the patient decides that they want to do the OLI, I make sure to verify their address so that I can provide that to the pharmacy that the manufacturer is working with. Also looking at BMI, and then we look at dosing frequency preferences that the patient has, as well as taking into consideration the preferences of the providers. So after the intake and documentation is complete and sent to the team, the benefit review process is started by sending an outpatient prescription to the Bartlett pharmacy. This allows us to see if the medication will be covered under the pharmacy or the medical benefit. Depending on the information that is returned, we follow a pathway approval of the long-acting cabotegravir or rilpivirine. A therapy plan is what is utilized to run the medication under the patient's medical benefits. And so I wanted to provide a visual of that preceding slide, so that I think me personally, I do better when I see it kind of laid out. An outpatient, starting kind of over here, an outpatient prescription is sent first to determine pharmacy benefit coverage. If covered, the nurse will then reach out to the patient to schedule them for their first appointment. However, if it requires a prior authorization, over here again, if it requires a prior authorization, then that process must be completed. And then we look at, we then have to try to reach out to the provider. A member from the implementation team will then reach out to the provider to get that prior authorization completed. Either a member from the implementation team or prior authorization team. I'm sorry, I wanted to correct myself. And so sometimes it's on a plumber, you'll see reaching out to the provider and putting documentation into the patient's chart about the PA that's required. If the PA is rejected, a therapy plan is placed to determine if the injectable is covered under the medical benefits. And so we go up here, and we have one medical benefits specialist who is actually doubling as a PSC, and that's Lori Hawthorne. She is actually responsible for Calling after the therapy plan is sent and signed by the provider. She's responsible for calling the patient's medical plan and verifying the authorization, whether the medication is approved or rejected. If the medication is rejected, then we'll try to pursue a patient assistance program through the manufacturer. However, if it's approved, then the nurse reaches out to schedule the patient to receive the injection through the clinic space by Stephanie Thornton. So we administer in both the pharmacy space and the clinic space.
Kristen, do you mind if I just clarify two things?
Yep.
Just to make sure everybody's aware, the reason we have to go these two pathways is because if something's billed through pharmacy benefits and filled through the pharmacy, any outpatient pharmacy, including ours, as we're probably all aware, it cannot be then given to the clinic to inject in the clinic due to regulation. So that's made it really complicated in Maryland to roll this therapy out. So that's why we have to have these two separate pathways and two separate staffs injecting this therapy, which makes it complicated. But you may also see we're starting, as we get more and more patients through this, we're learning some of the plans that already we know are required on medical benefits. So if you see, the outpatient prescription process skipped, it's because we already are aware, hey, this isn't going to go through pharmacy benefits, so we'll just go straight to the therapy plan part of the process for some plans that we've already learned.
Yes. Thank you, Matthew. So at the injection appointment, oh, sorry about that. My formatting is a little bit off. Stephanie Thornton and the Bartlett Pharmacy clinical pharmacy technicians provide patients with a one-day reminder phone call for their injection appointments, but this is in addition to the existing automated reminder system that is utilized by the health system. I see the patient arrives for their injection appointment, and then they receive their injection. And once they receive their injection, they're monitored for the manufacturer recommended time and sent to the lab if appropriate. So the lab monitoring that we're doing is standard of care. It's still standard of care. The patients that are able to receive the injection through the medical benefit, the therapy plan allows for us to implement a little bit of automation into it. And so I'm able to put these labs in and specify the frequency in which patients are able to get those labs done based on their dose and frequency of long-acting cabotegravir or rilpivirine. For pharmacy patients, it's a little harder, but standing orders can be placed by the provider or by myself if I've been given approval by the provider to place those orders. And that way patients, once they receive their injection through the pharmacy space, we can send them to the Bartlett lab if their insurance allows. To go get those labs done, and that way we're not always reaching out to the providers for labs, and it helps you guys can help you help the providers to already have those labs done by the time the patient comes back for their appointment, or if if they have an appointment between times, then the provider can still order those labs if need be. So follow-up appointments are scheduled by the front staff. The nurses that are currently administering the medication provide the patients with their appointments, and then they reschedule them with the front staff or through the pharmacy scheduling system. We're patients still having follow-up with their prescribers every 3 to 6 months just to check on their status, how they're doing with the medication. And then, as I said, providers are able to still send labs if necessary. So looking forward, as I mentioned earlier, we have Hang Dolly, who's our recent addition to the Bartlett Pharmacy, and she is our newest pharmacist, and she's currently training to be able to administer this medication to our patients. And we're hoping that she'll have a full transition by January 1st. to increase our capacity to be able to take more patients for the long-acting injectable. We're developing an Epic flow sheet to automate, again, continue to automate some of the data pool into the existing smart phrase to help with patient eligibility review. And as I mentioned earlier, also still looking at the visit adherence as a soft requirement and how we can make that more specific to the patient's adherence to ID providers visits. We are, as Eileen alluded to earlier, we are creating an Epic pool, and we're waiting on that to be taken up by the JIRA team. So stay tuned for updates with that. If you walk by the pharmacy here recently, you'll see this box outside of it. This is our construction area. We're super excited about this. Again, Matthew worked very hard with Hopkins administration to get this approved for us to be able to expand that space. And so expand into this space. And so we were able to take an existing storage closet that was in the pharmacy, and we're converting it to an injection room for our patients. And so again, trying to increase our capacity to be able to take on as many patients as we can and give access to the medication. So switching gears, and I wanted to talk about the confirmed virologic failures and resistance that we saw in clinical trials, that we've seen in clinical trials so far with the medications, with the long-acting cabotegravir rilpivirine. So we have three phase 3 clinical trials that are evaluating long-acting cabotegravir rilpivirine. The figure to the right shows the trial design for both FLAIR and ATLAS. As you can see, FLAIR was for treatment naive patients, and that included abacavir, dolutegravir, 3TC versus long-acting cabotegravir rilpivirine. ATLAS was our treatment experience trial with patients either continuing on their current ART or being randomized to long-acting cabotegravir. And then ATLAS 2M was our extension trial that looked at Q4 weeks dosing versus Q8 weeks dosing. The FLAIR trial was actually the trial that provided us with the data that made the oral lead-in optional. So wanted to give a brief breakdown of the resistance that we saw in the clinical trials. In the different mutations that were seen. Confirmed virologic failure in clinical trials was defined as 2 consecutive HIV RNA values of greater than 200 copies per milliliter. About 88% or 7 out of the 8 patients in the FLAIR trials with confirmed virologic failure had non-nuke resistance, treatment emergent resistance. And about 6 out of 7 of those patients actually showed reduced phenotypic susceptibility to rilpivirine, while about 5 patients had treatment emergent INSTI resistance mutations. In the ATLAS 2M trial revealed 11 confirmed virologic failures, and that was 2 patients in the Q4 weeks arm and 9 patients in the Q8 weeks arm at 96 weeks. About 8 out of the 9 of those patients in the Q8 weeks had NNRTI resistance, and that decrease in susceptibility ranged from 2 to 30-fold. And then 6 out of those patients also had INSTI resistance as well. For the Q4 weeks, both participants had NNRTI and INSTI resistance. But neither of those participants had the L74 INSTI polymorphism at baseline. All of the confirmed virologic failures with isolates with evidence of resistance to cabotegravir had cross-resistance to raltegravir and elvitegravir, but maintained phenotypic resistance or susceptibility to dolutegravir. And the isolates that were, the isolates for rilpivirine also displayed cross-resistance to all of the NNRTIs, including doravirine. So mutations if you're looking at the left box over here, mutations to rilpivirine with the asterisks were single NNRTI mutations that conferred 12 to 52-fold decrease in susceptibility. The larger red box outlining the mutations in the rilpivirine section were mutations that, if present at baseline, were likely to decrease the susceptibility of rilpivirine. And these decreases range anywhere between about 4 to 500-fold change in rilpivirine susceptibility in about 38 and 68% of the isolates. So the cabotegravir, for cabotegravir, the highlighted boxes conferred the greatest reductions in susceptibility, with the E138K and Q148KR conferring about an 81-fold reduced susceptibility to cabotegravir. So in this pooled, there was a pooled a post hoc analysis that was a pooled post hoc analysis that was conducted by Cottrell and Associates. The primary outcome was to evaluate the occurrence of confirmed biologic failures through week 48 of the pivotal trials FLAIR, ATLAS, and ATLAS 2M. Confirmed biologic failures through those 3 trials accounted for about 1% of participants, as you can see. Once in this analysis, once they excluded about 600 patients for the reasons that are denoted below, they found that about 13 patients ended up with confirmed biologic failure after exclusion of about 4 of those participants for prior exposure to cabotegravir or rilpivirine, as well as meeting the confirmed biologic failure when that patient was taking the oral lead-in. So I know this is a busy slide, but I was trying to make sure that I encompassed everything and I didn't leave anything. The figure to the left is the same figure that is down below in blue. It is just I just kind of blew it up a little bit, and it's marking the covariates that were analyzed in this trial by Cottrell and Associates. And so the authors performed a univariate and multivariate analysis of 10 covariates. In the univariate analysis, it was found the presence of each of the 10 factors was associated with a higher proportion of participants meeting confirmed biologic failure criterion, excluding the pre-existing NSTI mutations, therefore the L74I polymorphism. The multivariate analysis utilized a backwards elimination variable, and that multivariate analysis is the figure to the right. It utilized a backwards elimination variable selection algorithm to identify predictors of confirmed biologic failure. The covariate with the largest p-value was removed, and this process was repeated until no covariate produced a p-value of more than 0.2. So the 4 predictors that were statistically associated with p-value of less than 0.05 with increased odds of CVF were rilpivirine RAMs at baseline, week 8 rilpivirine trough concentrations, and then HIV subtype A6, A1, and then lastly the BMI. And these are highlighted in the red box. Other variables had no statistically significant association with increased odds of confirmed biologic failures. And the authors additionally sought to determine if the confirmed biologic failures could be differentiated based on the number of baseline risk factors that were present. And so in order for variables to remain in the model, they needed to yield a significance level of 0.05. So based on the kind of last analysis that was conducted to see about the number of baseline factors that were present, 3 patient baseline factors were found to be associated with increased risk of confirmed biologic failure, and those included the proviral rilpivirine RAMs, the BMI that was of 30 or more, and the HIV subtype A6A1. For the pooled data set, at least 2 contributing factors was seen in about a little over 3% of patients. And so that was about 35 patients out of the total number of 1,039 participants. However, 9 out of the 13 patients with confirmed biologic failure had at least 2 of those baseline contributing factors. In the multivariate analysis, 120 patients did have HIV subtype A6A1. 106 of those patients also had the L74I polymorphism. And this polymorphism, however, in this model was found was not significantly associated with confirmed biologic failure. But interesting that so many of the patients with the A6A1 subtype had that polymorphism. For participants with the subtype B, experienced confirmed biologic failure in the absence of the L74I polymorphism. And the subtype B was not associated with carriage of the L74I polymorphism. Only 1 patient with HIV subtype C also had the L74I polymorphism. So in the analysis, the authors also evaluated Q8 dosing and its risk for confirmed biologic failure. Looking at the solid circles and the solid triangles, you can see the patients with confirmed biologic failure based on Q4 week or Q8 week dosing. And so 69% of confirmed biologic failures had plasma concentrations for both drugs below the medium plasma concentration. And I've highlighted that in the red box there. I'm not sure about anybody else, but this was a little hard for me to kind of discern and look at. And so I just wanted to make it as clear as possible. Week 8 troughs, it was found that week 8 troughs concentrations for both medications were in the lowest quartiles of exposure for about 54% or 7 out of the 13 participants with confirmed biologic failure, regardless of dosing regimen. And so that was the second box that appeared. And the authors found that the dosing regimen was not significantly associated with confirmed biologic failure in this model. BMI was evaluated due to prior evidence of the slower absorption of cabotegravir in patients with higher BMIs. Patients with a high BMI were found to have a wide range of week 8 trough concentrations for both medications. Additionally, 6 out of the 8 with confirmed biologic failure and BMI of at least 30, which are the solid triangles, trended towards a lower cabotegravir concentrations that were in the first concentration quartile. So that's the red box area there. So a summary of the analysis, the pooled analysis done by Cutrell and Associates. About 75% of the significant covariates can be considered at baseline, and they're listed below. Subtype A6, a BMI of at least 30, and proviral rilpivirine RAMs. And at least 2 contributing factors were required to increase the risk of confirmed virologic failure to long-acting cabotegravir or rilpivirine. The next trial we'll look at is the data from the Atlas 2M, the trial from 48 weeks and 96 weeks. And I included this just because in the 48 weeks, in the Atlas 2M at 48 weeks, 8 of those patients had already experienced confirmed biologic failure. And so the table lists patients with confirmed biologic failure when the treatment failed and if resistant associated mutations to either component were present at baseline or suspected virologic failure. Again, 8 patients in the Q8 week, and 2 patients in the Q4 week experienced confirmed biologic failure by week 48. At week 88, 1 patient in the Q8 week cohort experienced biologic failure. He was actually from the United States with a BMI of less than 30. He had subtype B virus and was positive for the L74I polymorphism at baseline. He also had 2 major baseline NNRTI mutations, but no baseline INSTI mutations. So data from, this is data that was presented at CROI earlier this year for week 152. Week 152 brought a total, the total number of confirmed biologic failures in the Atlas 2M trial to 13 participants, with 2 additional patients experiencing biologic failure at weeks 112 and 120. What we learned is that most confirmed biologic failures occurred within the first year of therapy by week 48. So 10 out of 13 of the patients. 6 out of the 10 patients, or 60%, had 2 or more risk factors associated with increased risk of confirmed biologic failure that we've previously talked about. No participants with confirmed biologic failure had missed their injection appointments by more than 7 days, their scheduled visit appointments. And all patients except for 1 patient resuppressed on alternative therapies. And the rate of confirmed biologic failure has continued to remain low at 1%. So based on the current data that we have, providers should consider having a risk versus benefit conversation with for increased risk of confirmed biologic failure in patients with 2 or more risk factors, although the rate of confirmed biologic failure has been consistently low across the 3 trials. Archive GenoSure, consider sending out Archive GenoSure prior to starting cabotegravir or pivarine if the patient has an unclear treatment history, especially if they've may have been exposed to the NNRTIs. And then for patients with the A6A1 subtype plus a BMI of greater than of at least 30, consider alternative regimen. However, if the patient still would like to push forward, consider doing the Q4 week dosing for that patient. And that is it.
Well, thank you so much, Kristen. This is really amazing and such an excellent review. I think I'll open it up if anybody has any specific questions. I just wanted to ask if you guys have any feedback on the overall Bartlett experience of patient tolerability. Like, do people who are on this like it, and do they want to continue, aside from Joyce's 80-year-old?
Yes, yes. From what I hear, most patients have enjoyed it and truly are appreciative and like it. I think the biggest complaint, which is what was seen in clinical trials, is the injection site reactions and the pain that continues. And so we've had a couple of patients who couldn't tolerate the pain, and so they opted to get the injection at the dorsal gluteal site, and that has improved their experience. And
it sounded like there was 1 patient who was a no-show, sort of fell off outside of the side effects. There was at least 1 in our experience who did not continue to receive injections. Do you have any follow-up on that patient? Or, I mean, because I still think, my 1 patient who I'm hoping to advocate for this is not I mean, I know in your who's the best candidates probably wouldn't fall in the best candidate, but might be among the most needing of only needing to do the right thing like 6 times a year. But because, I mean, when you think about it that way, it's like revolutionary, right? Like if you do the right thing 6 days a year, as opposed to 365, like that is a revolutionary concept. But maybe not, I don't know. So just asking what your guys as the team who's been doing this thinks about that.
Yeah, so we, for that patient, we did reach out to the provider. And it was a conversation with the provider of, this patient has missed several injection appointments. We keep, reaching out to reschedule. They will schedule no-show, schedule no-show. And so it was a team decision that was made with the provider to put that patient back on their oral ART. And so as far as if we're looking at, again, those are soft requirements that we listed in those initial kind of ideal candidates. If you have a patient that you feel this would benefit, send them over. We can have a conversation because we want to, obviously we're here to help our patients. And so if we truly think that, the patient will benefit and this will help them, we'll do it.
And maybe I'll also just, Ethel, if you're in a place where you're able to talk, feel free to unmute, but use this as a moment to point out that there is still the ongoing trial of Cabenuva for people for whom it's not on FDA indication. And Christin, you're also helping to screen for that, is that right? Or evaluate whether.
Well, not formally, but I work with Ethel's team, just to answer a couple questions if I've seen a patient that they are interested in.
And Ethel, do you want to unmute or should I do the advertisement?
Yeah, so just to say how incredible Christin and Matthew's team have been at accommodating our ACTG 5359 participants who transition off study. Thank you so much for that. I know with a wait list of 96 people, that is a tough thing to do, and we really, really appreciate it. And all the collaboration and help has been so extraordinary, and the way that you've risen to this considerable challenge of implementing this has been amazing to see. So thank you. Christin, was it our participant who transitioned off injectables? Our former participant, is this the one?
Yes.
Yeah, so I can just say, just to speak directly to that participant, he received his injections on study with no issue. He does have some kind of psychiatric overlay. What we did to make his injections while on study go well is, I believe we did a lidocaine patch prior to injection, and then we did alternating cold packs and heat packs, and he always did kind of require a little bit additional, and he didn't complain and came for his injections each visit. And I think that he's a great example of the kind of patient who the study can help with, just like little extra person hours of this, TLC that sometimes actually is the difference between them being successful with injections and not. He also has a bunch of mental health issues, so any of those things could be going on as well. But just to say that the study does require you to suppress in 12 weeks is the shortest period you need to suppress. And then you have the 50-50 chance of getting randomized to Cabenuva. So it is potentially a way, 50-50 chance of a way to get your patients on Cabenuva potentially sooner than the wait list. So we would welcome any people who are interested, who you'd like to send our way. And also just to say, the efforts of the Bartlett Pharmacy have been really heroic. So thank you.
And just to sort of, go ahead, Matthew.
I was just going to add on that. I think that there will be a time, I'm hopeful, where we get to the place where we can have more capacity to have those personalized touches. I think it's at this point, just because we've been trying to lock down staffing to do all of this, once we get in a more stable position, I think and have more open availabilities for slots, it's easier to like reschedule a patient and slot them. I think at the beginning when we are transitioning and figuring out staffing, it's much harder because it's like essentially Sheila, like having to like drop everything she has and like find a way to make up this patient's injection appointment. So just kind of commenting, I think as we get more capacity, I'm hopeful we can facilitate some of these patients a little bit more that might need a little bit more TLC.
And also, Matthew and Ethel, I was just thinking, like, this seems like another potential role for peers. And if there's someone who goes on the injection protocol who wants to become an evangelist / navigator for that, it seems like again, as like some of the earlier conferences we've had even this year, that essential role that people can play in shepherding through encounters with the clinical system, that might be another place. Although I don't know if we have any peers who've actually been on injectable therapy, which it seems like actually having had the experience of the IM injections would be useful. But I don't know, Joyce, or anybody who knows more about that.
I think it's a great idea. I think it would be a great program. I can try to think about trial participants we've had who might be willing to serve in that role if the clinic can accommodate it. And yeah, Matthew, just to follow up, I think it makes all the sense in the world that with the resources that you guys are amazingly leveraging right now, it's not possible to kind of do some of that extra stuff. I wanted to ask, is there something we should be advocating for on a policy or legislative level to reduce some of these kind of mandated inefficiencies and staffing needs of needing to deliver it in 2 different spaces? Is that an easy law to change? Is it something that we can separately advocate for?
It's all about money, Ethel. So,
Yeah.
Unfortunately, it has to do, right? I mean, we have had these, so we're part of this Baltimore Rapid Start Collaborative, and we have special sessions about injectable ART. So with University of Maryland, Chase Brexton, BCHD. And I said in the comments, but it's really incredible what Christin and Matthew and Sheila have done. It's like amazing. And it's really difficult. They make it smooth, but it's really difficult. And so Ethel, it has to do with payers, right? Like what kind of benefit, it makes the difference if it's a medical benefit or a pharmacy benefit. That greatly impacts, especially there are some institutions that if it's under a medical benefit, they're not giving it to the patient because it requires the institution to pay up front and not know how much they're going to get reimbursed. And then there's, for any space that has regulated space, we already know that's an issue with a lot of payers. So sorry to jump in, but it's just, the clinical trials are amazing. It's an amazing intervention, but once again, our healthcare system is a barrier to implementing it. So there's a lot of manpower that goes into all of these things.
Yeah, that makes so much sense. Thanks, Joyce.
Just a comment. First of all, thank you. It's been so easy to get this done. Otherwise, my patients would never even consider this. I still am a little concerned about the failure rate, but I'll get over that as we get more data. Unrelated, and obviously for the future, PrEP, injectable Cabenuva for PrEP is clearly approved, and many of my general medicine patients would be very interested in that rather than the daily pill or the 2-1-1 PrEP. Clearly, we can't handle it now, but is there any future to look to where I can tell them, oh, it may be a year, but we're going to be able to offer that?
Yeah, I think once we have staffing that is resolved, we'll be able to offer it as soon as the staffing is resolved. It's passed through the institution and kind of ready to go, but we just need the staffing to be able to, track those patients and then be able to administer.
Yeah, I think it's definitely within the year, I would say, now that we have HANG starting. And once we start meaningfully working through this wait list, I'm thinking, 5 to 10 patients a month to start, probably realistically for this. So it might be realistically 8-9 months before we get all of those patients meaningfully started. And they may not all start based on what we're seeing. So, but yeah, I mean, maybe 6 to 9 months before we start. But I also think we could talk about, risk versus benefit. We've always kind of had those conversations with these patients, right? If it's a patient that we really want to get started, that's high risk and will really benefit from PrEP, we're willing to slot them in. I think we just need to come up with a workflow for aptitude here in the clinic and have plans to sit down and talk, between Joyce, Sheila, and myself and Christin on how we get this rolling now that we have more consistent staffing. And Sheila also is working with, Lisa Purdy and coming up with plans for, utilizing CMAs and leveraging CMAs and talking with the nurses and how we increase the capacity so it's not just reliant on Steph Thornton. So I think we will be in a much better place to come 6 months to get some Apertude patients started.
And we're also working on, so again, we have a PSC, Lori Hawthorne, who's doubling as our medical benefits specialist. And we know that our PSCs are busy scheduling our appointments. And so it's a lot to put on her. And so that's another reason of, kind of what has put a break on Apertude is that, I'm not sure if we could open the floodgate with that for her to be able to run those benefits and verify those benefits with those insurers at that point. And so working with administration right now to see if we'll be able to get patient financial services to help us out with running the medical benefits for those things.
Okay, great. So in the next 2 minutes, I'm going to do it. No, I'm not really going to do a case. So thank you, Kristen. I think actually we could probably talk about this for another 30 minutes, but I see there is one just comment left in the chat from David Block. If any of the pharmacology experts would comment on whether they would recommend a few months of concomitant oral coverage for any risk populations until drug levels get closer to steady state. And I'll just piggyback on that and say, I know the idea of if there are concerns, you could do that every 4 week. Has anyone actually tried to get that to fly with insurance? Because I think that was the other.
It's not a problem.
Okay, good.
You
So
can do,
insurance.
if you want to do Q4 week, that's fine.
Okay.
Apparently in Europe, they can only do Q8 week.
Yeah, that's what I thought was the only approval was for every 8, right? But I saw Charlie turned on, so.
I did. I can take a stab at that. The dosing schedule involves a loading dose. The first dose is 50% higher than the maintenance dose for the Q4 month. Q4 week. And the assumption is that everybody starting Cabenuva will do so with a daily oral regimen that has resulted in complete virologic suppression for a period of months. And so the assumption is that, assuming you took your pills the day before your first Cabenuva dose, you're going to be fully suppressed when you get your loading dose, and the virus will not be capable of replicating enough during those first few days, even if you have risk factors. So there's no recommendation for oral coverage, even for patients with risk factors.
Charlie, would you amend that if it was someone who is viremic?
So there are a lot of people who would not start a viremic patient on Cabenuva under any circumstances.
Because it's not allowed, but.
I think it's a big controversy because Monica Gandhi has actually reported that she's been doing this for her mostly homeless patient clinic at UCSF at San Francisco General. And she's had amazing success treating viremic patients from day one with Cabenuva with no oral lead-in. So clearly, at least in some settings, it can be done. Whether anyone here feels comfortable doing that and can get approval for it, I think that's really up. I think it's going to have to be a customized decision, but we may be learning more about when and how and in whom you can do this safely.
Yeah, I was just going to say we won't be learning more until we study them. And so I think studies that engage individuals who are viremic are needed. I've been wondering, David, about this strategy of overlapping with oral ART during your kind of period of building up to therapeutic levels. And I think it's something that could be usefully modeled, kind of try to look at kind of the benefit of doing that. We do know this accumulates, and we know that I think that period after the load is a vulnerability just based on the PK. But if you look at when these people fail, it's not all early on. In fact, a lot of them are out way further out. There's a few at 8 weeks, a few at 16 weeks. Those people makes me wonder about it. I think it's a great question.
It's just that the majority are between 30 and 90 days, I think. And so it seems to raise the question as to whether we're getting adequate coverage.
You know, I think there's evidence that the biggest risk period for most of these failures is at the beginning of treatment. Recognizing that there's limited experience with people who are very late for doses or have missed doses. My guess is that as this drug rolls out, if these drugs roll out more and more people are significantly late for injection visits, we're going to see more late failures. But you know, we just got to pay attention and hopefully create systems that greatly reduce the possibility of late injections.
And I'll take that just as the, since we're a little bit past the hour, as the point to again reiterate what's been said, but can't say it too many times. Thank you to Kristen and Matthew and Sheila and Stephanie and Joyce for setting up a system where any of us feel comfortable putting our toes in the water of this, because without that kind of a really clear system, it just would be, I think the risks would outweigh the benefits for many of us, at least in our minds, and we would not be allowing our patients to access what appears to be really fantastic based on the clinical trial data. So thank you. And also, I'm thankful for everyone in this group. Have a wonderful Thanksgiving holiday, and we'll see you back in the first week of December for Dr. Sarkar on cardiometabolic disease. And please do feel free to shoot cases along. I'm happy to work on prepping them for our upcoming conferences. So thank you all.
And Kristen, I'm assuming you would be willing to make your slides available after the meeting?
Yes.
Okay, great. That would be fabulous. They usually are, but it would be great. A great resource to have those. They were fantastic.
Fantastic job, Kristen.
Thank you.
Happy Thanksgiving, everyone.